Well, good afternoon, everyone, and thank you for joining us today. I'm Kelly Cooper. I'm the project manager at the Obesity Collective, and I am delighted to welcome you all to our fourth rapid talks to mark World Obesity Day. I'd like to begin by acknowledging the Gadigal people, the traditional owners and custodians of the land that I'm presenting from today, and I'd like to pay my respects to their elders, past, present, and future. I extend my respect to all Aboriginal and Torres Strait Islander people today. And I'd like to welcome you all to use the chat box to acknowledge the traditional owners and custodians of the lands from which you join us today. The Obesity Collective has a mission to change the way Australia thinks, acts, and speaks about obesity. To do this, we raise awareness of the science and the reality of obesity, acknowledging the complex systemic changes that need to occur to reduce the impact of obesity in Australia. Our leadership teams, which includes people with lived experience, researchers, clinicians, policymakers, and spans across prevention to treatment, represents a united voice that we must meet the challenge of obesity together. We welcome this year's World Obesity Day theme of changing perspectives. Let's talk about obesity. We need to talk about obesity. We need to talk about it respectfully and with recognition that many factors that contribute to obesity are outside of the direct control of the people who experience this condition. Today, we bring to you 13 presenters who are each experts in their own field and collectively bring you a diversity of perspectives on how we can meet the challenge of obesity in Australia. But before we move on to the presentations, there are just a quick few housekeeping items to get through. Today, we meet in a respectful place for our presenters to share their viewpoints. And so we ask that everybody respects all presenters and their perspectives. Everyone bar the presenters has been muted, and we'd appreciate it if you kept your mics off for the duration of the event. Each presenter only has 5 minutes to share their perspective, and this is really difficult to do. So as such, we won't have time to take questions and answers today. You are more than welcome to put questions in the chat box, and the presenter may be able to get back to you there. Otherwise, we can follow that up later. And if you are curious about a certain presenter, feel free to follow them on their socials as well. We are recording the event today, and if this makes you uncomfortable and you don't wish to be recorded, you can de-identify yourself by turning off your camera and changing your name. Now on to the show. We will start today with our first presenter, Ted Kyle from ConscienHealth in the USA.
I want to thank you for having me join you on this World Obesity Day. And on this day, what I want to do is look forward and back at the changes we have seen and are seeing in the realm of obesity. First, my disclosures, which are here, and then my objectives, which are to review a little bit of history, examine the reasons why we've seen limited success, and discuss progress that is emerging now, the perspectives that are coming from that progress, and ways that we might better cope with all of the change that we're seeing. First of all, we've seen 4 decades of relentlessly rising obesity in the US and all over the world. Back in the 70s, we thought most obesity with care could be prevented. That turned out not to be true. We latched onto low fat for weight control in the 80s. We came out with clinical guidelines for overweight and obesity, which were quite good, but had limited impact. Then in the 2000s, low-carb diets began to gain prominence, and a charismatic First Lady in 2010 launched the Let's Move program with the intent of raising a healthier generation of kids and ending the obesity epidemic within a generation. None of that worked out too well, and now we have big promises for plant-based diets to both reduce obesity and save the planet. Despite all this, obesity and severe obesity are still growing. And by the end of this decade, obesity prevalence will reach 50% in the US. Severe obesity is growing the fastest, and it will reach 25% by the end of this decade. Why? Why so little progress? Well, I would suggest that false assumptions can explain a lot about our failed efforts. Even today, people misunderstand, very smart people misunderstand what obesity is all about. False dichotomies lead us astray, suggesting that we have to choose between prevention of obesity and care for the people who have it. We have to choose between addressing the physiology that is driving obesity or lifestyle changes to adapt to it. We have to choose between dealing effectively with eating disorders or obesity. And we have to choose between paying attention to weight and paying attention to health. We have to choose between treating diabetes and treating obesity. Progress, as you can see, can be quite unsettling. But change is indisputably here as people gain experience with more effective treatments for obesity. There's no denying that it's having life-changing effects for some people. It's not miraculous, but it is greatly more effective than the options we had before. So we can best cope with all of this change by bringing some respect for the science that tells us many factors, not just food, are driving obesity rates. And they are interacting with complex adaptive systems to drive those obesity rates. But on top of the science, we have to have respect for people and the diverse perspectives about obesity that they bring, ranging from fat acceptance to health at every size, to self-stigma, to disordered eating, to cycles of weight loss and weight gain, and finally, to a state of being well-informed and engaged in the subject. So what I'd like to sum up is by saying that we can deliver progress if we can advance and translate science, if we can advocate for effective treatment and prevention, and if we can elevate the voices of the lived experience. Thank you.
Hi everybody, my name's Kristie. I am a nurse practitioner candidate based in South Australia. Firstly, thank you to the Obesity Collective for asking me to come and speak to you all today. I have quite a diverse background. I've been nursing for about 16 years, primarily in the chronic disease and complex health area of primary health, as well as ward nursing and things like that. But I'm also a lived experience person, and I've been living with obesity since I was a child. So I bring a very unique perspective of care and approach to care, in the fact of I've dealt with the stigmatisms and then I care for the stigmatisms as well. Next, please, Nancy. So my talk today is just briefly discussing perceptions and what is perception. So if we review the dictionary meaning, it's the ability to see, hear, or become aware of something through the senses. And it is the way in which something is regarded, understood, or interpreted. So in healthcare, it's using our skills to understand what is around us and to make assumptions, which is a horrible word, about the person that's sitting in front of us. We have 15, 10, realistically 5 minutes to meet, greet and treat a patient. And we use perception to help us make a therapeutic relationship. However, perceptions cannot also always be very helpful. Next, please, Nancy. So some positives for perception: it dictates the reality in which you see and live in. Obviously, there are a lot of substances and things out there that alter our reality. However, this is based on our clinical judgment, what we see, what we hear, often what we smell when we're dealing with people and patients and our community. It also talks on gut feeling and that intuition of something's wrong, what can we do? Next. The side effects of poor perception and perception that comes with judgmental bias. It creates a judgment of the person or their situation. So it makes a judgment about a person sitting next to you without them actually telling you their story. This can then in turn cause a breakdown of the therapeutic relationship and therefore make the person not want to reach out for help, which in turn causes poor health outcomes. Next, please, Nancy. So as a nurse, I've seen and I use perception to engage with my clients. However, I've seen the side effects of poor perceptions, and I've seen countless people too embarrassed to access help for fear of judgment based on their size. I've had patients tell me it's just the way I fit in the waiting room chairs. It happens naturally. We make assumptions based on what a person looks like in regards to their health without taking a full history or looking at the complexities that is obesity. The word obesity comes with some stigma, obviously, and for years like Ted was saying before, it was an idea that it was something that could be prevented with simple measures, and therefore if someone is obese, they clearly haven't followed the prevention education that's out there, which is not true. However, the person who is obese comes in with these ideas, is ready to be named and shamed, even though it shouldn't happen, it does, and therefore they have a lot of guilt associated, so they don't want to reach out for help. Next, please. So as a person living with obesity, my own health concerns have been overlooked because I was overweight and things were put down to me just being overweight. Symptoms that are quite often associated with being overweight, but are often associated with other things. I was left for 3.5 years with a tumour, which wasn't investigated because I was told it was just because of my weight. I've also been exposed to unnecessary testing. So because I was a big girl, it was automatically decided I was diabetic. So I have donated 6 hours of my time completing 3 GTTs, all for them to come back to say that I am not diabetic. And I've also found that a lot of clinicians have limited to no understanding of nutrition. They look at the latest guideline and they don't actually understand the complexities of what is nutrition and eating for health, and they're unable to look at treat the person with the whole person. So obesity isn't just what you put in your mouth, there's so many other factors that can contribute to it and can cause complications because of it. And the next one, thanks. So as a member of my community, I've seen people judged because of their weight, things like missing out on team sports, not being able to find seating, especially in waiting rooms. So there's those sorts of factors, physical, environmental factors that makes it hard for someone to reach out for help if they are suffering from obesity. I think one of the most interesting ones, the interesting phenomenon, is what's in my shopping trolley. So I'm a registered nutritionist, I'm obviously a nurse, and I'm a bigger person, and I feel judged if I put something in my trolley that's not 100% perfect. And we need to get rid of that idea. We need to be able to create a space for everyone to feel comfortable and to be able to enjoy life, not limiting their nutrition or their activity. Next one, please. So how can we improve these perceptions and make it easier for people to access support? Education. I'm a huge one, and if you'll sit with me long enough, I'll talk to you about things that we can change to engage people in our healthcare. We need to also create awareness around the complexities of obesity, and just like the work that the Obesity Collective are doing, we need to ensure that all practitioners from the first day they start studying or start the topic of endocrine and obesity, that obesity is a complex issue, and it's not just as simple as restricting your calories and going for a walk. We also need to keep an eye on the appropriate use of language and imaging in social media and the general community so that we're not unconsciously chastising these people. Just lastly, I just think this is a great summary of the power of perception. I'll tell you a story about Joe. He's quite excited because he has 3 meals a day cooked for him. He has company and companionship, which is unlimited. He doesn't have to do the dishes, washing or ironing, and he has no commute to work, which is fantastic. He gets exercise daily and he has endless hours for reading. Now, on paper, that sounds fantastic, but unless you unpack all of Joe's story, you realise he's in prison. He is in jail, he's incarcerated, and therefore he has no other option. But if we only take part of the story and make judgment on that, we think Joe's got it pretty good. So unless we take a full view and look at the whole person and their whole environment, we will never have holistic care. Thank you, guys.
Thanks very much, Kristie. And I'll just start by acknowledging the traditional owners of the land that I'm on here in Melbourne, the Wurundjeri people of the Kulin Nation. Acknowledge this land always was and always will be Aboriginal land, and any Aboriginal leaders joining us online or indeed presenting. My name's Sandro. I'm the CEO here at Vic Health, the Victorian Health Promotion Foundation. We're the world's first health promotion foundation. We're a statutory agency. We're part of government, but we work with government. We're independent from government. And we're established in the late 80s through taxing tobacco, hypothecating that money, protecting it and giving it or entrusting it to an independent statutory agency charged with really addressing the long-term deep structural barriers and inequities that result in poor health for so many Victorians and indeed Australians. Next slide. We know some of the challenges that we've been talking about already today. We have, multiple converging crises that are beyond the sphere of influence of individuals, maybe even individual governments. Cost of living, a climate crisis, which has seen a dramatic increase in the cost of healthy food over the last 3 years, worsened by a global pandemic, and then a conflict on the other side of the world, making healthier food increasingly unaffordable to so many Victorians, a doubling of food insecurity in just 18 months. We've seen a global shift in modernisation and commodification of our food system over the last 3 decades, and a rise in chronic disease to the point where 1 in 2 Australians are living with chronic disease. 9 in 10 Australians will die from chronic disease, and the average Australian lives with 11 years of pain and suffering as a result of mostly preventable disease outcomes. And we're also seeing enormous inequities. Young people and regional communities in Victoria continue to be left behind. And that's really the focus of one of the programs I want to talk about today. But I think it really is important, first of all, to thank Kristie for sharing her lived experience, but also other lived experience experts, the importance of embedding their voices and making sure that this is a truly, lived experience led and respectful conversation, and one that acknowledges that ultimately what we're talking about here is systems change. It's not pointing the finger at the individual. We need to go past blame and shame, and we really even need to go past weight. And that's why we have invested in a range of programs. There will be no single silver bullet when it comes to trying to improve the health and lives of Victorians and address so many of the structural, often intergenerational, commercial, cultural, and economic and social barriers that people face to good health. We've launched in the last few years a local government partnership, which works through local governments, 38 and counting now, embedded in their municipal plans to put the health and lives of young people and the priorities and health priorities of young people at the centre of their municipal plans, backed by money, evidence-based modules, and FTE. Soon we'll launch a Lancet series on the commercial determinants of health, a global series which we've helped to drive from here in Australia with a number of partners. We continue to work on important policy outcomes, and I'm hoping that many of you saw our recent collaboration with the ABC with Magda Szubanski, an example of how we're trying to move the national conversation beyond blame and to really a meaningful conversation around how we reshape systems for better health. Next slide. An example I want to share, though, from here in Victoria, which is a really strengths-based, place-based and action-oriented example, is our investment in the VicHealth Future Healthy Food Hubs. This is part of our largest ever single investment in the health, wellbeing and recovery of young people, a $45 million 3-year investment post-COVID, based around the insights of lived experience and led by community champion leaders, young people from across Victoria who've shaped this work. These hubs see the combination of 5 different elements: sustainable production through procuring local, sustainable, healthy food, increasing supply and safeguarding investments for local farmers and producers and bringing down costs, by fostering community connections across cultures, across age groups and across generations, by improving education in local communities, by increasing identity and belonging through safe spaces, particularly for culturally diverse young people, through and with food as the agent of change, and by providing employment pathways for young people to enter the food system, but also as food system entrepreneurs and advocates, in partnership with 2 very well-known social enterprise networks here in Victoria. Next slide. So we've launched these Future Healthy Food Hubs in 7 regional towns across Victoria. They've been built off existing food share programs to maximise the sustainability of what will ultimately be only a 3-year investment for us. And the idea is to really take the insight that young people, we're seeing a huge increase in food insecurity and cost of living pressures for young people, particularly across regional Victoria, that we know that unless people have access to affordable, fresh, healthy, culturally appropriate food where they live, good health is not about choices, it's simply not an option. And so how do we shift that and create place-based solutions that are disrupting local food systems and allowing young people a pathway in, but also leading to scalable, place-based solutions to improve access to fresh, healthy local food. And so whether it's Mildura up in the Food Bowl in the north of Victoria, Geelong, or indeed Toorong, which is out near, sort of halfway to Canberra, these all look very different, including the partnership with the United African Farmers and really working closely through the Ubuntu Food Hub as an example with the African Australian diaspora here in Victoria as well. Next slide. And finally, driving systems change requires a strong system. And so when we had the opportunity to reimagine our offices, this is a plug to you all. We'd love to see you. We reimagined our office space as a social good in and of itself and relaunched VicHealth offices when we moved to the doorstep of the regional transport hub here in Melbourne CBD, as a co-working space for the entire sector. And what this does is it sees us welcome now over 90 partners regularly into the space every week as a co-working space and an opportunity to drive that sort of more systems-based way of working, stronger collaborations, and of course, accountability and respect, all of which are required when we're talking about ultimately addressing this super wicked challenge of chronic disease. Thank you.
Hi, everyone. My name's Caroline Miller. I'm speaking to you from Ghana land. I'd like to pay my respects to the traditional owners and also to Aboriginal and Torres Strait Islander people on the call today. I'm going to talk about changing perspectives from, I'm a behavioural scientist and a public health policy researcher, and I'm going to talk about changing perspectives with regard to policy change and framing. I work in tobacco control as well as obesity policy, and I'm going to talk about reducing harms from smoking without blaming smokers and draw parallels to obesity policy. Next slide, please. So we need to reframe the problem from one of personal responsibility to that of a major public health challenge. We need to reframe solutions from being about individuals making different choices completely to the drivers of population behaviours and also health outcomes. And of course, we have different audiences within this. So we have individuals who we want to motivate and empower and assist. But we also have governments who we want to understand properly who we want to resource, and who we want to act in terms of policy reform. And then we have the media and the community, who we want to have a better understanding, be more respectful, and who we want to support evidence-based policy change. Next slide, please. So in terms of framing the problem from one of individual health concern to a major public health challenge, I think the parallels between smoking and the harms as a result of obesity are quite strong. So tobacco has been our biggest preventable threat to public health as measured by burden of disease for a long time. And obesity is the second biggest threat by our current metrics, and it's on the rise. We've got enormous burdens to individuals in terms of risks to health and health outcomes. We have smoking, which drives burden to the health system. We have equivalency in terms of obesity at a population level. And also we have costs to individuals, costs to the health system, and costs in terms of lost productivity. So we can see that they're both significant public health challenges which need to be taken seriously by government. Next slide, please. So then in terms of framing the problem once again, population level change is what is required, as opposed to perhaps current narrative, which is around individuals needing to do things differently. So smoking is a behaviour, it's a behaviour, and smoking's visible. People can see it, people can smell it. And obesity is something that we know is influenced by behaviours, at least at its inception. And again, it's highly visible. So smoking was something where the health consequences were stigmatised, and we know we face a significant problem an unhelpful problem in terms of stigma of overweight. Previously, smoking was seen as something that was easy to fix. So there were misperceptions that people or individuals could quit at any time. And I think those we know those misperceptions exist around obesity, so that people should just eat less and move more, or people internalise the view that they should just eat less and move more, and that will solve any problems. We also had problems in terms of risk perception around smoking. Smoking wasn't, when I worked in the field, lots of people didn't think smoking was really addictive, and the industry certainly denied that. And we also know we have misperceptions around risk with weight. So we know from our work that lots of people, young people, don't have any perceptions that they would be at risk of future obesity in terms of diets which are high in ultra-processed food and sugary drinks. And we know parents hold misperceptions as well. And I think one of the things we need to challenge is the view. So we know that a normal weight, whatever we call that, is no longer the norm. So we, at a societal level, we have a burden. Next slide, please. So in terms of framing the solutions, one of the things that we've been really strong on in tobacco control is evidence, evidence, evidence. And partly that's because, we were up against a competing narrative in tobacco control, and we are up against a very strong competing narrative about individual responsibility in overweight. We're also up against very powerful industries that are highly influential and have a lot to lose in terms of policies which might lead to reductions in smoking, and policies which might lead to reductions in overconsumption of ultra-processed food and beverage. So we've got very strong evidence around health burdens. We've got very strong evidence in smoking that it's more than just an individual behaviour. We have an interplay between behaviour and biology. We also know we have an interplay between behaviour and biology with weight, and that services are actually required and appropriate services are required. Once again, in terms of behaviour, we know that behaviour, or how people see things as individual choice, is more than just individual choice. It's driven by the environment, it's driven by the availability, advertising and price of products. Next slide, please. The other thing that we learn in public health advocacy is that we frame things in terms of Australian community values. So in tobacco control, we were anti-smoking and anti-tobacco. We were never anti-smoking. We were never anti-smoker, rather. We can also talk about the rights of the child to an open future. We have parallels between smoking uptake and also what happens in terms of obesity. And then fairness and justice are really strong and important values in society and in Australia, and we can use those in how we frame our policy advocacy around people's right to information and education, people's right to be protected from misleading marketing, and also in terms of the way we implement our other interventions. Thanks very much for your time.
Hi, everyone. My name's Tim Brodie. I'm from the Centre for Social Research in Health at University of New South Wales. Joining you today from unceded Darugland in Sydney, and just like to kick things off by paying my respects to elders past, present and emerging. Really pleased to have been invited to talk about stigma today at this event. And I think already we've heard some of the undercurrents of stigma coming through the early presentation. So there'll be a lot of synergies between what people have already spoken about and what I'm going to quickly touch base on over the next couple of minutes. So when we talk about stigma and mention that word, I think most people probably have some kind of preconceived ideas of what we mean by stigma. And I dare say that those ideas are generally quite accurate. It can look very different in very different contexts, can look like things like physical avoidance, aggression or violence, discrimination, unfair treatment. The list goes on, but basically an endless list of what stigma might actually look like in a practical setting. But essentially, when we're talking about stigma, we're talking about people being judged and treated as defective or less worthy. Some of the literature goes so far to use terms like being treated as not quite human, which is quite strong language. But when you understand the impacts of stigma, I think that's actually a really important message to try and drive home. Now, there's really no limit to the number of reasons why a person might experience stigma. And today for World Obesity Day, obviously, we're going to be drawing attention to stigma that people might experience due to obesity. But it's also really important to note that it could be due to any other number of things, things including gender, race, mental health, religion, disability, health conditions, sexuality. And again, that list goes on and on and on. And it's also important to keep in mind that when people are stigmatized for more than one thing, for more than one reason at any given time, the outcomes for that person can be much, much worse. When people do experience stigma, there's overwhelming evidence that shows that they're likely to experience a whole lot of negative impacts, things like lower self-esteem, social exclusion, difficulties in their relationships, poor mental health. Importantly, as we've already heard a bit about today, reduced access to healthcare and other services as well as harmful coping strategies. And again, that list can be much, much longer. So with all of that in mind, part of the reason that addressing stigma is such a priority is because it is a fundamental cause of health inequalities, and it's a barrier to action. That's why it's been identified in a number of different state and national health strategies. On this slide here, the comment about stigma remaining the single most important barrier to action was a quote from the UN General Secretary at an international AIDS conference back in 2008. And it's safe to say that that kind of statement still holds today, and not just related to HIV and AIDS, but to obesity and to many other stigmatized conditions and attributes as well. Next slide, please. So what can we do about stigma? Unfortunately, it's quite clear from all the research evidence that there is no silver bullet to solve the problem of stigma. But there is a lot of work going on, both in the research space and also in terms of lived experience, to start the process and to start that conversation about what does work. Much of the research has focused on stigma towards specific conditions or in various health fields. So there's a lot of research literature around mental health, things emerging around HIV as well, and around a few different other health fields. But it's important to note that the key lessons across all of those initiatives to reduce stigma are applicable to reducing stigma towards obesity and also to other attributes and conditions too. It's also worth noting that stigma is a priority in many different state and national health strategies, including the National Stigma and Discrimination Reduction Strategy, which is currently being developed by the National Mental Health Commission. So this has been identified at very high levels and in a wide range of contexts as a very key issue that needs to be addressed. At a practical level, when we're talking about how to address stigma, there are a few questions that we need to ask. There's the question of who the intervention initiative should be targeted towards. Things like, should they support and empower people who are experiencing stigma? No doubt that that's an important goal and something very worthwhile, but it does also tend to shift the responsibility of dealing with stigma to the people who are being stigmatized rather than those who are doing the stigmatizing in the first place. So that then raises the question, should interventions target the general public and try and shift public attitudes towards stigmatized groups like those experiencing obesity? Should interventions be more targeted to focus on groups like health workers or other professional groups who have a lot of close contact and work very closely with stigmatized populations? It's also important to note at this point that in most cases, at least, people don't purposefully go out and attempt to stigmatize others. This is a very complex process. It can happen when people don't remotely realize how their actions might affect other people, and they might be acting on the basis of attitudes and beliefs that they've developed over a lifespan from various forms of messaging that they don't necessarily realize that they hold. So we're not talking about people going out doing this on purpose, and we have to address that. It's a very complex and deep-seated issue that happens both at individual, interpersonal, and also at community levels. And that's just part of the difficulty in trying to address stigma towards any particular attribute. Research also acknowledges the importance of addressing structural stigma, and we have heard that touched on a little bit earlier today. When we're talking about structural stigma, we're looking at things like policies and procedures that exclude stigmatized groups, whether that's intentional or not. And things like Kristie's earlier example, talking about finding appropriate seating in a healthcare waiting room, is just one classic example of how structural policies, or just the way an organization functions, serves to stigmatize somebody just because of the way things are operationalized, and the negative impacts of that might not be so noticeable for someone apart from the person experiencing that. There are also questions about what these approaches to reducing stigma should look like. Things like having positive contact with people with lived experience can serve to, I use this in inverted commas, humanize stigmatized groups and help to change people's negative attitudes. Similarly, as we've already heard a bit today, education can really be useful in addressing misinformation and that information that feeds stigmatizing attitudes and behaviors. Looking at a broader level, there's a need for policy reform to counteract stigma at organizational and systemic levels. Now, to some extent, all of these different approaches that I've briefed on that I've touched on really briefly today have all shown some positive outcomes. There's research literature that talks about effectiveness and that something positive can come from all of these different approaches. But there's also a sense that none of these are enough on their own. There's questions about how long-term the effects of any individual approach can be, and how much of a change they can implement working just on their own. So to most effectively tackle stigma towards obesity or to anything else, really what we need to develop is a wide range of approaches, things that can specifically target in its various forms and in its various locations, and all of these things to work together to continue to increase public support for making positive change. Thank you.
Thank you, everyone, for inviting me to speak today. Deanne Minicon, I'm coming from Jagera Yagara and Yuggarabil People's lands today, and speaking to you around Aboriginal and Torres Strait Islander health, I guess. I've got two slides, and I just want to pay attention to this slide throughout the presentation, if that's possible. But I'm going to refer to the second slide now, which is all around the data and around how Aboriginal and Torres Strait Islander people are, their obesity rates are much higher. We know this. It's similar with chronic disease, whether they're adults or young children. And so we need to do a lot more around how do we prioritise, Aboriginal and Torres Strait Islander health and everything that we do. So back to the next, to the first slide, if that's okay. When we talk about obesity for Aboriginal and Torres Strait Islander peoples, we have to consider a number of things. And one of those things is, firstly, I always tell people is to look at our Australian history and the impact that that has had on Aboriginal and Torres Strait Islander people and where we are today in terms of our health outcomes. We need to look at the environments in which we live to support, that we live that either doesn't support or supports healthy lifestyles. And we also need to look at the strengths that are in our communities when we're trying to address obesity or any chronic disease issues within our Aboriginal and Torres Strait Islander communities across Australia. Now, prior to colonisation, and in the first, you can see the history up in the left-hand corner. Prior to colonisation, we were healthy people. And past policy, Australian policies have interrupted our food supplies and our food systems, our culture, and how that knowledge is passed down to our children. Aboriginal and Torres Strait Islander people had restrictions on places that they were able to access their natural resources, so restricted access to land since colonisation, and so there's been limited access to hunting and fishing practices that has constrained our access to nutritious and fresh food sources, which again can lead to poor health outcomes. So our original healthy foods back in past, prior to colonisation, our original healthy foods have now been replaced by a Western style food that are high in sugars and fats. So up until the 1960s or so, depending on where you are in Australia, Aboriginal and Torres Strait Islander people lived on missions and farms, and they were often paid in rations of the worst nutritional kind, which is your white flours, your refined sugars, your salts, your teas. So you can see the impact that history has on Aboriginal people today by removing us from our lands and our natural food sources to this kind of worst kind of foods that we now live with today. And so obviously the outcomes have impacted on us around obesity, chronic disease, and sort of physical distress as well. Access to affordable foods and nutritious foods is an ongoing problem, not just only in the remote rural communities, but also obviously in the metropolitan and regional areas. And while we're all affected by the extra costs of living today, wherever we live, people in rural remote areas have that additional cost of living, and they suffer from generally unavailable fresh fruit and vegetables and other high quality foods. And the experiences that I've had personally to be up in a remote community and, limited fruit and vegetables or fresh foods and the price of those foods, it's really difficult to live. And when you're being asked, and we can deliver as many healthy programs as we want, but if your environments aren't supporting those lifestyle, that to try and live a healthy lifestyle, then we're kind of struggling right there. Physical activity can be a challenge in some communities with animal management issues, and I'm not just talking about dog issues, we're talking about cattle issues, we're talking about crocodile issues, we're talking about, name it, snake issues. And so people, there are animal management issues. When we say just go for a walk and walk 20 minutes or walk 30 minutes, you have to take into consideration the people's environments around animal management, safe walking pathways, quality drinking water, and obviously shade. So where we've got up in the north, there's a lot of heat. We need to make sure people are safe when they're doing physical activity. It's also important to address that social and cultural determinants of health that lie outside of health sector. So we need to make sure that when we're developing policies around this space, that we need to think about the transport issues, the road, land, resources, education, housing, history, and cultural issues when we're dealing with these kinds of issues. So it's not just a health problem. It affects every single sector, and we need every single sector to come on board in making change. Now, I've talked about the deficits approach and, inadequate food and diets, food insecurity, poor dietary practices, but we need to change that language, and we need to take on a more strength-based approach. So when we talk about foods, like foods are around medicine. For us, food is just not eating to be, to keep ourselves from not being hungry. Foods are medicines to us. Animals and plants can be medicine. So it's more than just that. So taking that strength-based approach, a strength-based approach recognises the resilience of individuals. It focuses on abilities, knowledge and capabilities rather than what people do not know or can't do. We need to focus on factors that support health and well-being rather than factors that cause disease. We need an approach that's strength and expertise can be built upon and celebrated. We need to use the language, and it's been mentioned before, that's strength-based, non-judgmental and inclusive, and recognise complexities and have a commitment to social justice. And most importantly, we need to make sure that we value Aboriginal and Torres Strait Islander knowledge. Aboriginal Islander people have been nutritionists, dietitians, health practitioners for many thousands of years, and we need to value their knowledge and bring that into the work that we do. Thank you very much.
Thank you. Hi, my name is Liz Munn, and I'm from the Centre for Population Health in New South Wales. I'm speaking to you today from the Demaio lands in Sydney, and I'd like to pay my respects to elders past, present and emerging, and any Aboriginal or Torres Strait Islander people on the call today. So I wanted to talk to you a little bit about the New South Wales Healthy Eating Active Living Strategy, which was launched last year and really represents an evolution of our understanding of the issue, particularly in the complex drivers of overweight and obesity and the need to address it at a systems level. You'll see the goal there at the top. It aligns with future health strategy, that people are healthy and well, and that we're investing in preventing ill health and tackling health inequality in communities. The targets are obesity rate measures that ladder from the National Preventive Health Strategy and the National Obesity Strategy. And the objectives are around healthier eating and physical activity behaviours. The strategy itself is built around 4 strategic directions that are across the bottom there: prevention programs and services to support healthy eating and active living, routine advice as part of clinical care, social marketing to support behaviour change, and healthy food and built environments to support healthy eating and active living. So that's sort of a snapshot of the strategy. If I could have the next slide, please. The strategy's systemic approach to addressing the drivers of overweight and obesity has a focus on meeting the needs of priority populations, and you'll see those listed there on the slide in the circles. It's a pretty comprehensive list. And there's a particular focus, there's 2 particular focus areas. One's on closing the gap for Aboriginal and Torres Strait Islander people. And the second major area that I want to unpack in more detail here today is an increased focus on lived experience and a recognition of the need to minimise the risk of shaming or stigmatising people who engage with New South Wales health services, health programs or communications. So I'll just go through a couple of things that are going on in that space at the moment. In the healthcare space, we've got a number of activities underway to address the risk of exposing people to shame and stigma when they encounter our clinical services, when they come to us for help. So review and updating the training and support tools to help health professionals identify children who are above a healthy weight, and then sensitively provide advice and support to families and refer to statewide programs where that's appropriate. Also looking at developing resources and training to strengthen the confidence and competence of healthcare workers to prioritise the prevention of obesity while preventing weight stigma, and researching and enhancing the health workforce knowledge, skills, attitudes and behaviours, again, to address weight stigma. So what do we want to achieve in this particular area is really increased access to prevention advice and programs in clinical settings and partnerships between clinicians and patients to achieve personalised, kind, culturally safe and appropriate approaches to care in our settings. The other area that we're really looking at is around our public communications to ensure that all of our public-facing communications give people easy access to healthy eating and active living information, programs and services that can help them change behaviour. We're working on a digital platform that will link all of our health information on healthy eating and active living together. But we know that people want accurate and up-to-date information about healthy eating and active physical activity, but we're using research to really understand people's needs and to understand where, when and how they want to receive this information about making healthy lifestyle changes. Our research tells us that people expect us to take a supportive, positive tone when we communicate with them. And social marketing that emphasises the co-benefits of a healthier lifestyle motivates people to change their behaviour over the longer term. So this work includes developing and promoting messages and content which are informed by health literacy principles and that minimise shame and stigma. So it's very much at the forefront of what we're thinking about. And if we reflect on what we want to achieve through this work, it's really social marketing and communications activities that are shaped by customer insights to achieve greater reach and have wider impacts, and strengths-based inclusive approaches to social marketing and communications developed in partnership with priority populations in the community. So there's quite a lot of work in train, and there's always more to do to better support people living with overweight and obesity. And I'd just like to thank the Obesity Collective for inviting me to speak about a few of these on World Obesity Day. Thank you.
Hello, everybody. My name's David Burns, and I'm coming today from Gadigal country. This presentation is called Wellbeing Without Boundaries. And what we mean by that is it doesn't matter who you are or where you're from, you have the right to be a well-being. We're a social enterprise. And the best way to describe social enterprise for me is if you had a business and a non-for-profit and they had a baby, it would be a social enterprise. We trade like any other business, but we're here to make the world a better place. So our mission is to reduce health inequity within communities. And we do this through inclusive physical activity, well-being and employment programs, because employment programs are a big also of reducing health inequity. And we're really structured to provide for underserved, hard to reach and hardly reached communities. We are trying to tackle some of the social and systemic barriers of our time. We know that there's huge health inequalities, chronic diseases on the rise. So we need to change the way we do things. We work in community with interventions, but we recognize that we're actually part of the problem as well, because these health inequalities are getting worse. So we're actually leading a systems change project in Western Sydney, where we are trying to reduce physical inactivity across the system, working with all the different levels and different stakeholders. We align with the Sustainable Development Goals, which are the good health and well-being and reducing inequalities. Next slide, please. So there's been a lot today talked about obesity and that it's a complex, wicked problem. We know that there's multifactorial causes to obesity. It's not getting any better, unfortunately. And there's some really great ideas here today of how we can try and change that. But I'd like to talk to you about the inner development goals in a second. Shifting perceptions, in my industry, which is the sport, leisure and physical activity sector, we have these wonderful facilities, but really it's only the fit and healthy that get to use them. And the people that really need it often miss out. And even in our collateral, and how we market these facilities, it can for some people be, you can be turned off by it. So we need to change the way we do that. And because like I said, these systemic problems that we've got are actually getting worse. We need to remove barriers. And it's easy to say that, but it's about providing caring, safe environments where people feel respected. Here's a project of ours, a sports mentoring program where we've got, we're working with disengaged youth, and they come from all shapes and sizes, but it is providing that environment. And back to our purpose as a business, as a social enterprise, it's about enabling well-being without boundaries. So again, it doesn't matter who you are, where you're from, you have the right to be a well-being. So we can provide these safe and welcoming environments. Now, you'll have all heard about the SDGs, the Sustainable Development Goals at a macro level that we're all trying to work towards to try and change some of these significant systemic challenges of our time, including obesity. But we're not really getting anywhere. And the SDGs, for those that already know about them, the Inner Development Goals, these are transformational skills to help us to achieve the SDGs. And there's actually 23 skills, and they're divided into the 5 categories there. And we try and take this into all of our work at Collective Leisure. And these are the things that we need to look at ourselves, what is our inner compass? Self-awareness, presence, sense-making, connectedness, humility, trust, presence. How are we showing up in the world? How are we influencing it and interacting with it? Because I think, being human, we've got many dimensions, and the dimensions we've been good at exploring the outer world. But to complement the outer world, if we can look in the inner world, in a perspective of how we're interacting and influencing and showing up, then I think we can really look at changing some of these challenges of our time. So just wanted to thank the Obesity Collective for the presentation today and allowing me to speak. And thanks to everybody else for listening.
Hello, everybody. My name is Dr. Terry Lynn South. I am both a dietitian and a medical practitioner. I'm a specialist GP. And the reason I am here is I'm the current chairperson of the RACGP, that's the Royal Australian College of General Practitioners, specific interest group in obesity medicine. I'm speaking to you today from the Turrbal lands, and I'd like to pay my respect to the elders past and present of our First Nations people. Thank you so much to the Obesity Collective for giving me the opportunity to talk about changing perspectives in regards to obesity and obesity management. I'm very lucky to be here, and I could talk underwater and forever about obesity management. And I had to limit myself to only talking about one option. Next slide, please, Nancy. And I want to talk about people living with obesity and their access to care from the viewpoint of a general practitioner and how general practitioners can actually help improve patient access and care to both prevention, screening and treatment. Most people will see their GP as their first port of call for health concerns. In fact, the Australian Institute of Health and Welfare states that on average, Australians see a GP for a consultation anywhere between 5 to 6 times per year. And we know that more than 1 in 3 Australians meet the definition of obese. With these two statistics, I think it underscores the potential for general practitioners to help patients living with obesity. GPs are often that first access point for healthcare, and therefore GPs are in a great position to do much to help change perspectives on obesity and help change access to care. GPs see people living with obesity every single day, yet these same GP patients struggle to access support. And why is this? I think there are many reasons, but stigma is one of the most significant barriers. GPs can reduce stigma perpetuated in healthcare by promoting better understanding of the science and complexity of obesity. We need education of healthcare practitioners. We also need education of patients and education of the public that the science of obesity shows us that we are living in complex drivers as well as our genetics, and it's not the sole individual's responsibility to manage their obesity in themselves or in their offspring. I think education also needs to show why it's so difficult to maintain any sort of weight loss or even to prevent obesity, and that there are better ways to diagnose and manage obesity compared to 25 years ago. I also believe that GPs can reduce stigma by simple measures such as the physical environment in their own practice, waiting at consultation rooms. Having weight and size appropriate chairs and equipment is a very small but achievable start that all GPs and other primary healthcare practitioners can do. GPs can also reduce obesity stigma by helping change the perspectives in regards to obesity is chronic, it's complex, and we do need a multi-pronged approach from the top down, but also the bottom up. There is much scope for GPs to change the dialogue around obesity. We can reduce stigma and discrimination and participate more in prevention, screening, and evidence-based management. I've been a healthcare practitioner for more than 25 years, and if I look back and think about all the things that has changed in our understanding of obesity and obesity management, it really has come a long way. But that new information has not trickled down to my colleagues, and it certainly hasn't trickled down to our patients and the public. We talk about patients living in a larger body needing to be brave to approach their healthcare practitioners about their concerns. But I also encourage GPs to also be brave within their routine patient care by routinely assessing obesity clinical markers and asking patients in a non-judgmental way if they have concerns about weight-related health conditions. We need to be open, we need to be non-judgmental, and we need to be patient care focused. I encourage grassroots GPs to take a special interest in obesity management and prevention. Thank you for listening to me today.
Hello, I'm Dr. Claire Pulker, Principal Public Health Nutritionist at East Metropolitan Health Service in Perth in Western Australia. I'd like to begin by recognising the Whadjuk people of the Noongar Nation as the traditional owners of the land I'm presenting on today. I acknowledge that the Whadjuk people have a continuing spiritual and cultural connection to this land and pay respect to all Noongar elders past and present. I welcome all Aboriginal and non-Aboriginal people listening to my presentation today. At East Metro, I lead a small team of public health nutritionists and dietitians who collaborate with stakeholders with the aim of maintaining and improving the health of 1/3 of the WA population. Our stakeholders include researchers, primary care partners, clinicians and community representatives, and we couldn't do our work without them. Today I'm going to talk about how we are using the Shift Guide to change perspectives in WA. The Shift Guide is a locally relevant, practical guide to support WA health system communication staff to work in a non-stigmatising manner when reporting on obesity. The need for a guide was highlighted during the co-development work undertaken to develop our obesity prevention strategy. It was also highlighted in the work that informed the WA Healthy Weight Action Plan, which was developed by the Health Networks Unit at WA Health in partnership with Health Consumers Council in WA and the WA Primary Health Alliance. Our East Metro Obesity Prevention Strategy was launched in 2020 and was the first test in applying the Shift Guide, where we made sure we followed our own advice. The current public conversation on obesity often focuses on an individual's behaviour and choices as the single cause and solution. In response, our strategy highlights that we recognise that over 100 complex, interrelated and reinforcing factors can lead to excess weight gain, overweight and obesity, and many are outside a person's control. The Shift Guide was developed in 2020 in consultation with 12 communications representatives from across WA Health. Our approach in developing Shift started with communication staff because we felt it was important to check that we in the health sector were all using best practice before asking others, such as journalists, to make changes. There are some other Australian guides which are excellent, but the key point of difference with Shift is that we co-designed this guide with communication staff to ensure the end product was fit for purpose and practical to use. We have some examples of the way the Shift Guide is helping to change perspectives in WA, and they include supporting GPs to have respectful conversations about weight with their patients by featuring the guide in the WA Primary Health Alliance SHAPE website. It's also being used to support WA Country Health Services colleagues to talk with patients about weight by being translated into an e-learning course. Master of Dietetics students are being upskilled during their coursework at a local university using this guide. Consumers can also help call out stories in the media that they consider stigmatising and offer the guide as a tool for positive change to journalists. Public health dietitian Kristie has also pre-recorded some presentations to assist with translation further afield. In summary, communications professionals in our own organisations can play an influential role in changing perspectives on the complex causes of and solutions to obesity. We can all reflect on how we can talk more about obesity in a respectful way and how to do more to support consumers when this doesn't happen. I've included a link to the guide, which is located on the WA Health website, and I hope that it's helpful. Thank you for listening.
Awesome. Hello, everyone. It's a pleasure to be here today. My name is Benjamin Zargar, and I'm a second-year medical student and researcher from Deakin University. And before starting medical school, I've worked in obesity advocacy and clinical care field for 5 years, and I thought for today it would be beneficial to talk about my experience and my perspective from Canada and how obesity management was done and is being done there. And in particular, talking about the group medical visits because they are relatively new concepts, and I think that's something we could utilize more in Australia for obesity care. So for the people that may have never heard of the concept of group medical visit, these are physician-supervised interactive groups that provide education to patients living with chronic diseases. And they're meant to be supportive, and there are quite a lot of literature on the efficacy of it, especially in improving the health outcomes for people living with chronic diseases. So it's not just obesity, but also diabetes care. And the group medical visits do provide that social support and the motivation and the accountability, which we know that are very important for long-term chronic disease management. And because they're run in a group setting, they are cost effective. So that provides an opportunity for the healthcare practitioner to provide more comprehensive care to a larger group of patients. And the education provided are meant to empower individuals to be able to stick to their healthy goals and also have sustainable lifestyle changes. And if you go to the next slide, I just have an example of how multidisciplinary obesity clinic is run in Canada. So Nancy, if you could go to the next slide. Perfect. Yeah, so this is just one example. Obviously, there are so many other clinics in Canada, and some of them may use group medical visits, some of them may not, but this is a clinic I had experience with. It's called MedBait, so you can search it out if you're interested. But in a clinical context of how the program was run, it was pretty much in combination with twice yearly medical follow-ups. The group medical visits were offered in much more frequent basis, and patients were advised to attend at least a couple a month. And these GMVs, while they provided the education, these follow-up appointments allow for personalization of the plans, because as we know, each person has different lifestyle and different needs. And this is obviously very practice dependent. I've seen some programs that have less GMVs, more one-on-one, some programs more GMVs, less one-on-one. So it's very much dependent on how the program functions. And in terms of who runs these groups, in that program, specifically, a lot of groups were run by allied professionals, so dietitians, kinesiologists, nurses, or people with health or nutrition backgrounds, such as myself. And there was always a physician present to supervise the group, answer any sort of medical question, and also allow for billing the provincial healthcare system. And if the groups were medically focused, sometimes they were run by the physician. So if it was a group specific for sleep apnea or diabetes, they were the ones that were run by the physician. And before COVID, everything used to be offered in person, but the positives of COVID was that we were able to switch online, and that opened avenue for patients living in remote and rural communities, or also the patients that didn't want to drive every week because they had family commitments or they had to work, and that made it more accessible. And I think that's something we could definitely look into Australia, given that we do have a large community of people living in remote and rural settings. And the topics covered are pretty much obesity specific, so nutrition, mental health, medications for obesity management, or even surgical therapy for the patients that are interested. But again, the courses offered in any particular clinic could be tailored to pertain to health conditions covered by that clinic. So that's pretty much open to change. And the last time I checked with the team there, there are more than 4,000 active patients. So that is pretty good in British Columbia with a population of 5 million. This is just one single clinic, and having more than 4,000 active patients, that's a very good number. And the best thing about it is that it is free of charge. So everything, it is covered through the provincial medical service plan. So all patients can attend this program for life, theoretically, if they want to, without paying anything out of pocket. And The reason I brought this up is maybe we can think about how we could utilize and scale up GMBs in Australia to support more patients living with obesity. Obviously, there are differences in the healthcare system, but as an idea, this could be considered because as we've heard from other presenters, and as we all know, it's a very complex medical problem and requires different approaches to be addressed. Thank you.
Hi everyone, my name's Nuala Byrne, and in starting I'd like to acknowledge that I'm joining you from the land of the Palawa people of Lutruwita, Tasmania. When given the opportunity to talk today, I considered the question, how would I change the narrative? And to start with, I thought about this from a needs analysis perspective. So what more do we need in order to change the narrative? And in the academic world, where I've spent much of my career, we tend to focus on gathering data to form an evidence base upon which to answer questions. And we tend to look for holes in the current literature and make the case that these holes need to be filled so that we can find solutions. And when the case is made, we apply for research funds to address a hypothesis or a research question, and we design research projects, collect data, interpret results, write manuscripts, receive peer review feedback. And sometimes after much to and fro, the manuscript is published. And then what? We hope that the findings are of value and that can some way lead to solutions to a problem at hand. And so my changing perspective is that the continual quest for new knowledge may be, in part of the problem. Now, we live in a world of information abundance, and this is depicted in the images in the top of the slide. The ease with which anyone can now access information, particularly through the internet, is unprecedented. But even if all this information accessible through the internet fire hydrant could be absorbed, how much of it would the general public make sense of and know what to do with the variety of findings and instruction and opinion? And how well are the conflicting opinions and proposed recommendations reconciled? And for decades now, I've been working in the field of energy metabolism. And over these many decades, the volume of published work in the field has increased exponentially. For example, if we look up a public health search, a PubMed search, using combined terms such as energy intake and energy expenditure and weight, it reveals that there's over 21,000 manuscripts that have been published over the last 3 decades. And more than half of these have been published in the last decade. But what is translated from all of this research investment? And in a recent conversation regarding the impact of prevention strategies on unhealthy weight gain, a colleague commented that obesity rates have not been impacted by prevention strategies, not because prevention has no positive impact, but because there's not been a real commitment to obesity prevention strategies. And so the comment got me wondering, what if what we wanted to do was change the narrative? Do we really need more data? Or do we need to stop wasting the data and well-described findings already at our disposal and commit to more effective translation and implementation? I wonder if we should stop and ask ourselves, are we there yet? Do we really need more research and evidence base before we can come up with an action plan? Does the action plan need to be perfect before we act? Will any more data really help us decide what action needs to be taken? Or are we at the point of diminishing returns in some areas? And is it time for a little less data collection effort and a little more translation action? So just turning to the next slide. I've always loved this citation from Marcel Proust's book, Remembrance of Things Past. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. So rather than seeking new research avenues, should we take stock of what we already have and see how we can get the most out of it? How well have many of the existing peer-reviewed research findings been translated into healthcare practice and into policy? And if not, well, why? maybe we need to seriously consider the impediments to implementation. The existing strong evidence, advice and guidelines need to be made more accessible, or at least more visible within that internet fire hydrant for individuals seeking support to achieve health and wellness. And we need to demystify the evidence. The weekend before last, I was surfing the waves at Pirate Spade Beach on Eagle Hawk Neck down here in Tas. And I was spoilt for choice with wave after wave rolling in. And I was able to float over the top of the swell, letting many good rides float by. And I was waiting for the better wave. And how good were the waves that I let go? Look, I'll never know. Maybe we need to jump on these perfectly good waves of evidence already available and see how far we can travel, rather than wasting time and opportunity waiting for something we hope will serve us better. Thanks for the opportunity to chat today.
Hello, my name is Claire Mullen and I'm here today from the Weight Issues Network. It's really quite fitting that the topic for this year is Changing Perspectives, Let's Talk About Obesity. Because at Weight Issues Network, we have indeed been talking about obesity a fair bit over the last year. On this slide are just some of the images of how members of the Weight Issues Network team have been getting the word out and talking about obesity and being part of efforts to change perspectives. This year, or in the last 12 months in October, we joined many of the people here today at the International Congress on Obesity in Melbourne, where a number of WIN lived experience speakers spoke on panels and in plenary sessions, and we also ran a workshop focusing on engaging people with lived experience in research. The other items that you can see are some news items, and it's been really heartening to see the level of interest from some of Australia's biggest media outlets in having a really nuanced discussion about obesity. And what has been great is that the team at the Obesity Collective have, when approached, always encouraged the journalists to reach out to the Weight Issues Network and connect the journalists with people with lived experience so they can really get that perspective. So earlier this year, we saw an article in the Weekend Australian where there was another article prompted by Taryn Brumfitt's appointment as Australian of the Year in the Sydney Morning Herald and The Age. And one of our membership also took part in a programme on ABC 7:30. So I think it's fair to say that members of the Weight Issues Network are both really interested and also doing their bit to change perspectives, but there's so much more still to do. This week, on Zero Discrimination Day, on the 1st of March, we held a WIN community conversation, giving people who are impacted by weight issues the opportunity to talk about obesity. And when we went round and heard from the people who were there that evening, the discussion and the things that people wanted to talk about fell into three main categories there on the screen: advocacy, information and support. And those are some of the comments there that people shared on the evening. There was a real note of the importance of advocacy and also the importance of looking after people who are involved in advocacy in this space. There is the information about making sure that both in the public there is better information and more is understood about the science of obesity, but particularly also so that people impacted by weight issues have better access to evidence-based information about treatments that are effective and where people can really make their informed choices. For example, a comment from someone who said, if I'd known about other options, treatment options that were available, I might have made a different choice. And the important thing about people being fully informed and supported to understand both issues about the effectiveness and potential risk of any treatment options. But when we were asked to choose a topic from these three, the group, many people in the group wanted to focus on this question of support. I think it's fair to say that while we are starting to see a change in perspectives, that it's still really challenging for many people impacted by weight issues to access the right treatment, access support, and be able to feel confident when speaking up to advocate for themselves and others in their family. So as we round off the Obesity Collective session on World Obesity Day, I'd just like to reiterate our interest in working as partners alongside practitioners, researchers and clinicians, and the power of supporting people with lived experience to find their voice, to share their stories, and for those stories and those voices to be heard and acted upon. So we're really looking forward to continue the conversation and changing perspectives. Thanks.
Thank you everybody so much for attending today. And we hope you walk away feeling like you've learned something. I'm sitting in the room with 3 other people at the moment. We each work in the space of obesity, and I can tell you right now that we've all learned something here today ourselves. We also hope that we've impressed on you the importance of the collective voice. We've heard a diverse range of perspectives, and we've heard of a lot of action happening. And I think it's fair to say that a health and social issue this complex needs many voices raising awareness of it. And on that note, if you are not a member of the Obesity Collective but would like to join the cause, please sign up on our website, just in the membership tab. There's no cost at all, but what you do is you actually just again, raise more awareness of this very important cause. I think it's fair to say there were several key themes today to be drawn from all of our presenters. The first one being that weight stigma is an issue. It's unfair and it's a serious barrier to health. The second thing would be that there is a need for systemic approaches. There's no one thing that's going to solve this issue. We need people to work together, and we need different systems at different levels to work together to really solve this. And of course, going back to the person, because this is what this is all about, there is an absolute need for person-centered care and holistic health. In the next few days, we'll be sending out an email, a thank you email to you all for attending. In that will be, again, just a reiteration that if you would like to join the collective, there'll be a link there to do so. We'll also be popping in there an engagement survey, and we'd really appreciate you filling this out, because that will determine what our engagement looks like over the next little while. Really important for us to keep an eye on that. If you have any questions whatsoever, there weren't any questions that came up in the chat today, but if you do have any questions, please feel free to email us there at info@theobesitycollective.org.au. And last but certainly not least, we'd really like to thank all of the presenters for attending today and speaking today and sharing their perspectives. Thank you so much. Everybody enjoy the rest of your Monday afternoon.